Good afternoon. My name is Dr. Danny Melker. Previously, I did a DVD for Dental XP on furcations and the management of these areas when doing periodontal restorative comprehensive care. Today, I'd like to discuss with you the treatment of the maxillary first bicuspid and the mesial concavities present. If we'll look at the picture that you can see, what you see basically on the left photograph is the area reflected and then a curette entering the area to try to correct any plaque or calculus that's present in the concavity. The photograph on the right simply shows it sutured back in place. This technique was devised to allow for better access to the mesial concavity and other areas where irregularities on the root surface were an issue. This procedure was called the modified Widman flap. The problem that I have is if the cause is a concavity and we don't remove the concavity, why wouldn't the problem reoccur down the road? So today we're going to spend our time talking about ways to treat the concavity. I find it very difficult to treat a concavity when there's not to be any restorative commitment, because in essence we do need vertical access, which requires a provisional. So if I'm not to be in a situation that I'm going to have this provisional, I'm inclined to think of other options such as bone regeneration or in fact the use of the periolase performing a LANAP procedure. But I just don't like to go in there and do pocket elimination without treating the cause. So didactically, when we look at this area, again, you can clearly see that it's nice to have vertical access because we're in fact going to remove the line angles adjacent to the concavity. In doing so, we basically work on the mesial buccal line angle and mesial lingual line angles and blend them into the concavity. In picture 2, you can clearly see a burr which is angled vertically, and that's why I said to you the key to the case is to have vertical access, which requires the need for a provisional. But this burr is angled vertically, and in essence what we're going to do is blend the line angle so that it no longer is thick and in fact becomes smooth, that it becomes part of the concavity, and in essence we just remove the concavity. Picture 3 shows the beautiful convex surface that certainly floss can manage and a curette can manage as far as removing of plaque. So I want you to take a moment and think about what we've really done here. We've changed the environment. We've created an environment that can be maintained long term. So that's what I like about this, is that it's a removal of problems or causes that create periodontal disease. If we can treat causes and not effects, the good chance stands that we will not get a reoccurrence of the problems. When you look at the upper left picture, the dotted areas, the very light gray areas are the areas where we would remove to surface, and the real black area is the area that we would try to leave alone. Again, the goal is to shape line angles into the concavity, thus removing the concavity. This is a photograph taken from Dr. Howard Kay's article in 1987. But if you look at it, particularly the occlusal view, and see the darkened areas again, we're going to work on the line angles and in fact remove those dark areas. If you look at the arrows and dark areas, that is where we want to work to correct the concavity. Certainly when you do biologic shaping, you need to remove all CEJs, so you would have to work slightly in the area of the concavity, but not aggressively. This is another didactic picture taken from the 70s. You can tell basically this is a very old case because you don't see any core buildups. Today we would never do a case and not have a massive amount of tooth structure present, which is certainly be accomplished by doing a core or composite bonded resin. Looking at the dotted areas, this is the part of the tooth that we want to remove. So let's focus only in on the bicuspid and see again that we're talking about removing line angles to shape them into the bifurcated area or concavity. A normal occurrence that every periodontist will tell you he finds is when you reflect tissue back, you can see a concavity filled with calculus. Again, this type of procedure to me, if we just remove the calculus and close the area up, would continue to progress over time. So when I do get into areas like this, I try to work on the line angles to remove them as best as possible, but I do not advise this type of technique. This is a very difficult technique and really truly doesn't accomplish what we want. Looking straight down this tooth, this is a post-shaped tooth that was done incorrectly. This was done by a periodontist who looked at this tooth and thought of how he would handle a molar and burrowed in the concavity, thus creating a worse situation than if he had left it alone. As I told you, I previously did a video on molars, and you certainly can pull that video up and look at how we handle molar furcations and how we address the removal of the furcations. In this case, the periodontist should have been working on the line angles, and instead he worked in the concavity, creating a worse environment. The arrow clearly shows the deep concavity we presently have now that actually was created by the burr of the periodontist. So what we'd like to do is lay a flap, remove the provisional. If cores needed to be placed, the cores were placed, and now have vertical access to work on the line angles. You can clearly see the calculus present as well as the concavity. After biologic shaping has taken place, the line angles are gone and the root surface is perfectly smooth. Take a moment and look at the root surface and envision in your mind the way a piece of floss or the way a curette would work on this surface. It would be a beautiful surface to have any plaque or calculus removed with a curette or floss. This is the day of impressions, and I will spend a minute with you to explain the way my restorative dentists take their impressions. You are looking at a number 7 Siltrex cord. It is placed only in the sulcus and for only one reason. This will allow the lab technician to have room to trim the die without touching the margins. It is not placed for any other reason. You'll also notice that all the root surfaces are perfectly smooth. There's no CEJs remaining, and any irregularities have also been treated. Now let's just address tooth number 5. Notice the perfectly smooth root surface and no longer any concavities. This would be a very easy area to maintain. The preparation on these teeth is a light chamfer with a 0.3 of a millimeter margin supragingival to the tissue, just supragingival to the gingival collar. We do not place our margins in the sulcus. Let's go ahead and treat a case together. So what we're looking at now is the provisionals removed. You're looking at Duralon cement on the teeth. And the beauty of Duralon cement is it is antimicrobial. So in essence, we are protecting the teeth and trying to avoid sensitivity that is caused by plaque getting underneath the provisionals. We want to make our pulps calm and relaxed, and this will help to avoid sensitivity. Upon reflection of the tissue and looking at the arrow location, we are looking at a concavity on an upper first bicuspid, tooth number 12. You can clearly see the calculus coronal to that just under the CEJ. And again, that's why we remove CEJs. It's another rough area that accumulates plaque and calculus. Just apical to the arrow is a defect in the bone related to the concavity. When I'm doing definitive periodontal restorative treatment, I don't like to consider doing bone regenerative procedures which can have questionable prognoses. So in this case, we're going to remove the defect through osseous contouring. Upon further treatment, what I'm going to do, and I always start with using my burrs first, is I'm going to take a C847-016, a C847-016 burr from Axis Dental Company. It is an end cutting burr with coarse diamond grids on the surface. It has minimal taper, somewhere around 4 degrees. The burr is to be placed, or burr tip, just where the bone and tooth surface meet and gently moved around the tooth 360 degrees, removing all accretions, all CEJs, and creating a perfectly smooth tooth surface for further treatment. More importantly, the interface between the bone and tooth surface is perfect. There is no more defects, and it allows for the tissue to lay over the bone in a harmonious fashion. Here we are using an F847 burr. F847 burr. The F stands for fine. So you can see that the tooth surface is even becoming smoother. What we're trying to get is an environment where the root surface is perfectly smooth for 360 degrees and meets the bone at a perfect interface for long-term maintenance. The arrow that you now see is located to show you where the periosteum is when I've reflected my flap. What I'd like to do is always save periosteum because it will be the material I use to suture my flap too. This burr is a C801L. C801L, and again from Axis Burr Company, and the phone number is 1-800-355-5063. Let me clarify, I don't care where you get your burrs from as long as they are similar to these burrs, and in particular they are not chamfer burrs. Chamfer burrs would ditch the margins of the bone if they were used properly. You can go back to the video on furcation treatment, and I show you the different burrs and the reasons we only want to use an end cutting burr. Here we have sutured our tissue in place. It is critical, in my estimation, to try to do periosteal suturing of your flap. The reason being is you can then place the flap wherever you want and know that it will stay there. In this case, we have placed the flap just coronal to the bone. We never want to expose bone if possible, other than in the very middle of the tooth where we can't prevent it, but we certainly don't want to expose bone on the buccal or lingual. This helps for a significant amount of decrease in discomfort and much better healing since we have primary closure. The arrow points to the location of where I have placed my suture to attack the periosteum. Because I did do osseous surgery, my periosteum is not present for about 4 to 5 millimeters apical to the gingival collar or the bone. So the suture must enter the periosteum up in this 5 to 6 millimeter area to grab the periosteum to tack the flap in place. So what you are looking at is a flap that literally can't move. The final restoration, and you'll notice that the tissue has no clue that the restorations are in place. These are all feldspathic porcelain restorations with supragingival margins prepped to 0.3 of a millimeter. In the real world, it's hard to get a lab to really do feldspathic porcelain unless you have your own lab. I would recommend, frankly, using Emax since it will give you almost the identical result and sometimes even better cosmetics. You can talk to your lab about doing deep chamfers which run 0.5 to 0.7 millimeters, but there's no reason to do any type of shoulder or deep prep that would decrease the amount of tooth surface that we'd like to have present. Moving on to another case, I'd like you to take a minute and look at the flaps. The flap in this case has a perfect architecture and maximum preservation of the papillas. Why this is so important is when we put the flap back, the papillas are going to go interproximally as far as possible, creating as much primary closure as possible. It's important to remember that bone must mimic soft tissue. So when doing your osseous surgery, you can use the flap to dictate the contours of the osseous. In this case, we have significant amounts of exostosis that you can clearly see. It ranges from 3 to 5 millimeters in a buccal direction. We're going to have to contour all that bone away. Why? Because the flap must go over that bone that's present, thus being in more of a coronal position than it should be on the tooth surface. We want to create an environment, again, where the bone mimics the soft tissue and the soft tissue can lay closely adapted to the tooth surface. The arrow points to the exostosis, which are considerably significant in this case, and again run to 3 to 5 millimeters in a buccal direction. The next arrow shows you the periosteum present. So in this case, I did a full thickness flap followed by a split thickness flap. What I suggest is before you start any incisions, you take your finger and feel the thickness of the buccal bone. If it is thick, you know that a full thickness flap must be started, and if it's very thin, you could do a split thickness flap if you want all the way down. However, sometimes it's best just simply to do a full thickness flap and then a split thickness flap so you can do any osseous contour you want. Again, we're going back to starting on the tooth surface first using a C847-016 coarse diamond burr. Same as the other case, I want to create an environment with a perfect interface between the bone and tooth surface. Remember, there should be no margins remaining when this procedure is finished. I'll repeat that. No margin should remain when this procedure is finished. I then progress on to the F847-016, the superfine burr. Simply compare the left photograph to the right photograph and you can see the decreased diamond grids on the burr. Again, it must be a burr that is end cutting and has no chamfer type end tip, and a burr that has minimal taper. Take a good look at the teeth and you'll notice that they're still extremely large. This is not an aggressive procedure. It's a very gentle procedure, keeping the maximum amount of tooth surface possible. Going back again, you can see where the arrow is on the left, and notice that I want to make sure that the burr is touching the bone and tooth interface and is not creating any ditching or anything that can't be corrected by the use of a diamond round burr. Now there are times you have to ditch a little bit to get the bone proper, in other words between the two teeth, but you would come back and treat it with the diamond round burr, smoothing the interproximal so that it would be a parabolic architecture. Here I am taking again the number 8 diamond round burr, which is the C801L, and gently smoothing the bone so that it's removing any areas where my burr at the interface, using the straight burrs, may have caused a little changes to the bone, but this would be normal to create an ideal interface. I'm also removing the exostosis, which you can clearly see in this picture. You also will see by the arrow a large marrow space. This is very common to find when doing excessive osseous on exostosis. You can also look at the elevator and still see periosteum remaining. As I said to you, this is going to be the area where I'm going to suture my flap and use the needle to penetrate the periosteum, thereby holding the flap in place. You can take a minute to look at that because it's kind of important to understand the critical nature of bone and periosteum and the need to keep the periosteum for suturing. Here you clearly see the flap sutured. You'll notice about 6 millimeters from the gingival collar is where the sutures enter into the flap, engaging the periosteum underneath and coming out. This again tacks the flap down to the periosteum and the flap cannot move. What's the beauty? You can place your tissue exactly where you want it and it will stay there through the entire length of healing. I want all flaps to be just coronal to the bone. As I said, I don't want any bone exposed other than a minor amount interproximally, which you can't help but avoid. In looking this case, again, from an occlusal view, the flaps come in, and then there is a space interproximally which you cannot avoid, but you want to make sure that preservation of your papillas is crucial, and that therefore the healing will be much greater in terms of much less discomfort for the patient and much quicker healing because of primary closure. This is the day of the reline. The reline takes about 4 weeks to come about because that's the period of time for the tissue healing. The only procedure that should be done at the reline appointment is to close the existing margins of the provisionals in place so they fit the tooth surface. Since I've modified the teeth by shaping them, the provisionals are going to be open, and what they will have been filled in with at the time of surgery is cement. So they're not wide open because cement's there, but once you take them off, they are wide open. It is critical to teach your dental assistants about where to reline these provisionals to. They are to end 1 millimeter short of the tissue. This is critical because biologic width changes will occur over the next 8 weeks. If the dental assistant puts the margin of the provisional to the tissue over the next 8 weeks, you're going to get tissue moving in a coronal direction, which will become inflamed and irritated, and it will be a very poor type of tissue for a perfect impression. Also, very important, no prepping of the teeth is to occur at 4 weeks. These teeth are to be left alone. The other advantage of leaving the provisional short is that when you use your materials to decrease sensitivity, such as Vanish or Prevident, these can get directly on the tooth surface and seal the tubules. So that space actually works to help us long term in decreasing sensitivity. I repeat, the provisionals must be left 1 millimeter short of the tissue, or you will have inflamed tissue 8 to 10 weeks down the road. The photograph on the right is a day of impressions. In a way, it almost mimics the picture on the left, except further healing has occurred. Once again, we are using number 7 Siltrex cords, only placed to allow for the lab technician to be able to trim the die without touching the margins. In this case, a 5 to 7/10 millimeter chamfer was placed by Dr. Howard Chaslin, a phenomenal prosthodontist in Sarasota, Florida. He is going to be placing all Emax restorations with the exception of 2 and 15, which will be full coverage gold restorations. So now we look at the final restorations. Again, we're looking at Emax restorations with the margins left supragingival. The margin depth is 0.5 to 0.7 millimeters in a chamfer fashion. Tooth number 15, you're looking at a all gold restoration, obviously. And if you want to go back to the other video that I did, it talks about beryllium infiltrations and their treatment. Certainly you can clearly see the furcation burrowed into the occlusal surface. I discussed with you in the other video the crucial nature of having the furcation burrowed into the occlusal surface. So today we've talked about the treatment of a maxillary first bicuspid concavity. The important points are that we'd like to treat the line angles and not in fact the concavity. Now we at times will have to clean the calculus out of the concavity or plaque, but this is a very gentle procedure. The main shaping takes place on the line angles. In biologic shaping, we are going to remove 360 degrees of tooth surface wherever a CEJ is present. If you would like, you can go to an article in the compendium written by John Rapley and Charlie Cobb, and in it, it's a wonderful article about the location of biofilm and the CEJs and how the CEJs literally always have biofilm present. So once again, if we're going to treat causes, in my estimation, if we can eliminate any rough surfaces on the tooth, we're going to stand a better chance of long-term maintenance of that area. So this is the nice article that you can pull up to read, and will explain to you the need, in my opinion, to remove these CEJs which harbor biofilm. I can't thank you enough for the time that we've shared today, and look forward to doing another video with you in the future. Have a nice evening.